Welcome, everybody. Certainly glad to have a large number of participants. We're rapidly rising above the 70s, and we know that it'll be a great evening. So it gives me great pleasure to kick us off a little bit on this is the second year of our every other month presentation, continuing education on program on special care dentistry. And we've had outstanding speakers, and tonight is no exception for sure. Dr. Jeff Lichtman from Touro is going to speak, and Susan, Dr. DeCenzo will introduce him in a minute. I would just like to say that we've made great strides. To me, it's really a pleasure that Dr. DeCenzo and Dr. Ozdolski have taken this on as a passion to put together the program, to put together our fellowship program, which Dr. DeCenzo will tell you a little bit about in a minute. But that this whole idea of doing it is really to increase the awareness of general dentists, students, that this is an incredible need to educate people and taking care of individuals who've been marginalized for such a long time. And so for us, it's a mission on getting this done. And certainly the long-term goal is to be able to develop a clinical site in which we can actually provide care for individuals who have been marginalized. Special education in any of these programs takes support. We obviously give these programs at no cost to the attendees. On the other hand, we cost us something from time and resource to do it. And so we certainly would appreciate support of the program. We have certainly the rest of this year, and we will continue it as we go forward. But obviously a non-taxable donation to support the Special Needs Fund at Touro, and it's available on our website. And as I said, no gift is too small, just to keep the program going. And with that, I'm gonna be quiet. I'm gonna turn it over to Dr. DeCenzo.
Good evening, everyone. I just wanted to take a moment to thank the many individuals who over this time have been in support of our efforts and collaborative work together. If we took time to mention everyone individually, it would probably take several minutes, which is a wonderful thing to think about, that there have been so much collaborative efforts, and we hope that that continues. As Dean Myers mentioned, I did want to mention about the NISAC Fellowship to address oral health disparities. This is through the New York State Academic Dental Centers. There are 6 within New York State, and we are currently accepting applications for the fellowship for this coming year, starting in July. It's a year-long fellowship whereby the individual would provide direct care in a clinical setting that specializes in serving people specifically with intellectual developmental disabilities, alongside experienced dental faculty mentors. And 20% of their time would be devoted to teaching and or research at one of these 6 New York academic dental centers for the duration of their fellowship year. And then it does include a following year after the fellowship where fellows will commit to at least a year in practice settings in New York State with significant special needs patient populations, and to continue their teaching and their research responsibilities. And so our hope is that we continue to provide opportunities for individuals who want to learn more and develop their skills, and also develop a network of individuals across all of the 6 New York academic dental centers, and hopefully expand from there. And if you do have any questions, you can feel free to email me. You can let Stephen know when you're returning your responses for tonight as well. And now to our feature presentation. I do want to thank Dr. Jeff Lichtman for being here with us today. Dr. Lichtman is Director of Student Mental Health Services, and Lucille Weidman, Director at Graduate Jewish Education and Special Education at Touro College and University System. As Director Emeritus of Yachad, the National Jewish Council for Disabilities, Dr. Lichtman is well known for his more than 30 years of visionary leadership, where he grew Yachad into a worldwide force for inclusion, innovative programs serving children and adults with disabilities. A psychologist with many years of experience in a variety of settings, Dr. Lichtman has master's degrees in psychology and education from St. John's University and NYU. He received his undergraduate and rabbinical training from Yeshiva University, where he completed his doctorate as well. His areas of expertise include individual and group counseling, social skills training, and teacher training. Dr. Lichtman is a member of the New Jersey Department of Education Non-Public School Advisory Commission and was president of Kushner Hebrew Academy. Dr. Lichtman, thank you. We are very happy to have you here with us today. And with that, I will hand the floor over to you.
Okay, so thank you. Thank you, Susan. Thank you. It sounded like my epitaph. But you know, there's always a disconnect. You know, we put together you know, a bio or description, you know, in advance of these things, and we forget that somebody might actually read them. So anyways, I think really in some ways I want to, first of all, I want to thank you all for joining us tonight, for caring enough to want to learn more and to better understand individuals, whether children or adults, who have disabilities and what some of their challenges are, how to work with them, how to help them. I think in the long run, we help ourselves when we help them as well. But I think my, in many ways, my strongest suit of expertise comes from the fact that aside from anything else, I'm also the parent of children, including an adult son who has Tourette syndrome. It's comorbid with ADHD. A successful adult psychologist, better psychologist than his father. I'm also the grandfather of 6 beautiful grandchildren. One of them, my grandson Teddy, has dyslexia, and significant dyslexia. Very bright boy, but he has dyslexia. And while I have learned over the years, you know, we learn in school, and then we learn certainly through our experience, our clinical experiences, our interactions with children, adults, their families. You know, I certainly have learned from my own children and my experiences what it's like, and I can never know fully, but what it's like to have different kinds of disabilities, what it's like for the family members of those who have children or siblings or other family members with disabilities. And so I hope to share a little bit of that with you tonight so that you, in your practice, hopefully will be able to be more sensitive and understanding and able to serve anybody who has any kind of special need. I'm going to stop several times during the presentation, you know, at certain junctures to allow for any questions or comments. And then again, at the very end, I'll do that as well. Let me turn to the PowerPoint now, and let's hope that I can get to it. This is it. Always have some tech. Oh, wait.
Susan, you may have to make him host.
Do you see the PowerPoint?
Hold on, I'm going to make you co-host. Dean Myers is correct.
Right.
And now you should be able to share your screen. Let's try that one more time.
Second. We practice this before too, and I do this all the time. Okay. Do you see it now? No, right?
Not yet.
How about now? Still not?
Nope. Are you able to hit stop screen?
Green
Or stop
button,
share?
please.
Okay, one second.
Green button.
I don't see any buttons. Oh, wait. How about now? You see it? Still not.
Nope. You know what? If you'd like to send it to me, I can send it on my end if you'd like.
Share your first screen.
Okay, well, wait, share screen now.
There you
Yes,
go.
please. Uh-huh.
Perfect.
Okay,
We can see it.
yay, okay.
Good to go.
Now you can see it? Okay, good. Okay, so I want to set the stage by reading this to you. You can read along as I read it to you. This is by Emily Kingsley. Emily Kingsley is a fairly well-known writer, TV producer. She spent many years working on Sesame Street as a writer, and she is also the parent of a son who, at this point, must be in his early 40s, a son who has Down syndrome. And this was something that she had written some years ago. I went to my dad and I said to him, Dad, there's a new kid who's come to my school. He's different from me and he isn't too cool. And he's nothing at all like me. No, he's nothing at all like me. He runs in a funny, jerky-ish way and he never comes first in a race. Sometimes he even forgets which way is first base. And he's nothing at all like me. He studies all day in a separate class and they say it's called special ed. And sometimes I don't understand what he said, and he's nothing at all like me. No, he's nothing at all like me. I know in the lunchroom he has lots of fun. He loves hot dogs and ice cream and fries, and he hates to eat spinach, and that's no surprise, because that's not very different from me. And he's always so friendly. He always says hi, and he waves and he calls out my name, and he'd like to be friends and get into a game, which is not very different from me. No, I guess that's not different from me. And his folks really love him. I saw them at school. I remember on open school night, they were smiling and proud and they hugged him real tight. And that's not very different from me. So I said to my dad, hey, you know that new kid? Well, I've really been thinking a lot. And some things are different and some things are not. But mostly he's really like me, like me. Yes, my new friend's a lot like me. If I share nothing else with you tonight, I really believe in many ways she has captured the essence of what it is in some ways to have a disability. And certainly for us, perhaps without disabilities, although we all have our challenges, but how to view, how to understand, because nobody wants to minimize the challenges that come with any of a variety of different kinds of disabilities. But at the end of the day, fundamentally, every child or adult with a disability, whether it's an intellectual disability, whether it's a physical disability, whether it's a neurological disability, it doesn't matter. Fundamentally, they're human beings first and foremost. So if I leave you nothing else, some things are different, many things are not. And mostly he's really like me. Mostly she's really like me, like you, like all of us. And let me remind you as we continue that depending upon those who are citing the estimates, anywhere from 15 to 20% of the population in the United States has some kind of disability. 15 to 20% of individuals in the United States have some kind of disability. That means it's likely, seems to me, that 1 out of 5 or 6, certainly, of the individuals who might be working into your office have some kind of disability. It might be a hearing impairment. It might be a visual impairment. It might be some other physical challenge, or it might be an intellectual or psychological challenge. So let's try to unpack disability in general a little bit, and then we'll touch on some of the different, more common areas of disability.
Beth,
Yeah.
are you advancing the slides? Because if not, they're.
Oh, it's not advancing?
Yeah.
Oh, how about now? Still
No.
not?
No.
Okay, how about now? Still not?
No.
try this again. How about now?
No.
No. Why slideshow? Still not, I assume, right?
No, it's not.
Jeff,
Um,
just try one more time, stop share and then reshare again.
Okay. Stop share.
And now let's do that green share screen button.
Okay. How about now?
Yes.
Okay.
So that's your fourth slide, right?
Yep. Okay, so that's where I want to be. Good.
Yeah.
Thank you. Thank you for pointing it out. I apologize.
No.
Okay, so you can all see on the screen now two tables. Which is bigger? Which is larger? Or perhaps are they the same size? And at the end, different shapes, rectangular, more square. At the end of the day, these two tables actually measure the same size. And yet, in appearance, certainly at first blush, they look different. And I think that we need to all remember that appearances can be very deceiving. And again, a lot of the things that I'm going to share with you tonight, I think, are things that you might even already know or be familiar with. But I think we all, even if you are, I hope that you find it beneficial to be reminded. Certainly, I find these reminders are beneficial for myself. And I want to point out to you that as human beings, we're wired to make decisions and determinations in the blink of an eye, almost instantaneously, right? It harks back to the time where we, perhaps needed to, be alert, even more alert to danger than we need to be. So constantly we're making determinations. But I also want to point out to you that very often these determinations are wrong. Not always, but often. These determinations help us to form opinions. And often these are opinions that we're forming on a singular experience. I meet one individual who has autism, and I then determine that I know what it's like to have autism, or more to the point, what autism is. Oh, okay. But in point of fact, not. And autism spectrum disorder in particular is called a spectrum disorder because that spectrum is so wide. You can have individuals on the one hand who are significantly intellectually challenged beyond, in addition or as part of their autism. And you can have other individuals on the other side of the spectrum, frankly, who you could engage in conversation. You would never know there's any intellectual disability because there is no cognitive or intellectual disability. Broad spectrum. And some of this, let's also keep in mind that some of this is not hard science. Some of this is both theological and societal in nature. 10 years ago, the DSM, which is the diagnostic manual that guides psychology, psychiatry, etc., had a narrower definition, again, for autism. And then when the 5th edition came out, they widened it tremendously. Widening it means that there is a broad spectrum. And when you meet an individual with autism or Down syndrome or a learning disability or hearing impairment, all that you've done is met Joe or Jenny who has that hearing impairment or that intellectual disability. They do not represent individuals with that kind of disability. They represent themselves. Now, it may be, certainly they share, elements in common, but again, it's not just autism spectrum disorder that's a spectrum disorder. And point of fact, every disability that we speak of tonight and in general, every disability is a spectrum. And you can have it more mildly or more severely or more moderately, and it can manifest often in different ways. Slide. Okay, so briefly, what is a disability? For a very long time, we thought of disability as evil, as a manifestation of sin. It was, we really had no good way of relating to it. In more modern times, we've come to see it from a medical model as a biological deficiency or abnormality. I can tell you for a fact that the overwhelming majority of individuals who have disabilities do not want to be seen as an individual with a biological deficiency or an abnormality. And it starts with a human being. And everybody has the right to be seen and understood in the way that they want to be seen and understood. So do disabilities require rehabilitation? Sometimes, and sometimes rehabilitation can be very helpful. Institutionalization? Never. Virtually never. And yet, only in the very recent past that we've begun to significantly deinstitutionalize individuals with more significant disabilities. And what a poor reflection on us. Part of that was a reflection of, our lesser understanding of disabilities, different kinds of disabilities. And part of that just represents perhaps a more immature, if you will, kind of society. And I want to point out to you, before we leave the slide, one other thing. When I went to college a few years ago, in psychology courses, we were taught about autism. Again, I'll use that as the example. And in psychology, a science, I was taught that the cause of autism was, I hope you're sitting down for this, was cold mothers. Cold mothers. Mothers who were cold, distant in their interactions with their baby. That's what caused autism. Not many years later, psychology, science understood that was ridiculous. And I'm using that term, ridiculous. But when I went to college, that was the science of the day. That was the understanding scientifically. Today, we would laugh at it. Much as I hope we laugh at the notion, actually, we don't laugh sufficiently, at the notion that vaccines cause autism based on one illegitimate, fraudulent study done in England. One study, which was not a legitimate study, fraudulent, reported inaccurate information, yet in our age of social media, introduced into the world the notion that vaccines cause autism. What a terrible, terrible tragedy. I want to tell you, the individual responsible for that, forgive me, I'm really speaking terribly out of turn, but that person should burn in hell. Because not only has it affected terribly the lives of families who have children, or whether adults or as children with autism, but it's actually affected our society in a larger way in terms of the perspective about vaccines. And it is all based on falseness. So we have to be very careful when we talk about what we understand, even our understandings today of what causes things. And while we, thank God science is rapidly, developing, and we understand more and more and better, there's still so much we don't know. By the way, I think it's a little bit ironic, but in the recently, one of the causes of autism has been linked to males as opposed to females, as opposed to mothers, but actually fathers, and fathers who are older when they have children. Isn't that interesting? The science 40 years ago, mothers who are cold, and now with better understanding, one of the causes, not the cause, but one of the causes may be fathers who are older when they have children. All right, let's move on. And what I want to move on to now really is I'm going to, in the next few slides, share with you some of the more common areas of disability and something about them. Obviously, we're only touching on them, and I'm really, not doing it justice. I can't do it justice in the limited time that we have. But again, I hope I'll give you a little bit of an insight, maybe clear up some of the inaccuracies that may be floating around out there, like some of the ones that I just touched on, and just, again, give you a little bit of a starting point to work with. Okay, well, let's start with physical disability. Right, physical disability is in some ways the easiest to understand, right? Somebody's physical functioning is impaired in some sort of way. It might be mobility impaired, right? They may not be able to move around in the ways that we more typically can. It might be, their hands. They may not be able to move hands, lift things, whatever. It might be their senses, visual, auditory, hearing, etc. The most important takeaway is to remember that a physical disability has nothing to do with intellect whatsoever. Nothing. Now, is it possible that an individual can have a physical disability and also have some kind of cognitive challenge? Absolutely. But they don't go, it's not part of the physical disability. It's just that sometimes, unfortunately, people may have more than one area of challenge. But they don't go together. Now, I gave you one example of a physical disability, is cerebral palsy. And cerebral palsy is an interesting, dare I say, what a poor word to use. But it's kind of an interesting area of disability. In fact, let's go on the next slide. I think that's right. Okay. It's a disability caused by some damage to the brain, and typically either before, during, or shortly after birth. It is manifested, right? We see it with varying degrees of fine or gross motor difficulties. And again, think spectrum. I've seen people with cerebral palsy who really, you could hardly tell that they have anything, any kind of difficulty. It's only if you spent maybe a lot of time with them, maybe if you looked at their handwriting, and by the way, honestly, their handwriting wouldn't be much different than my scribble, So again, sometimes really not easy to tell at all. And then on the other hand, it could be somebody who's, as part of their cerebral palsy, might be mobility impaired, right? Might need to use a wheelchair, for instance. And again, or everything in between that. I have a young man that I worked with some years ago, Stephen. Stephen has cerebral palsy. Stephen graduated from George Washington University. He got a master's degree, I think also from George Washington, in public policy, was an eloquent speaker, very bright. It took him 2 hours every single morning to get ready to leave his apartment. 2 hours to wash, get dressed, to whatever it was necessary for him to get out of the house. 2 hours. 2 hours every single day. I typically get, I don't know, I'm sure we all have different amounts of time we take with our grooming, but if I need to, I can be out in 10 minutes, right? 15 minutes, 2 hours, never less, every single day. And that's before you get to, he leaves the apartment and then he goes to the subway, and the elevator that takes him down to the subway is locked. Locked. Just locked. I didn't say not working. I said locked. Other times it's not working. But sometimes it was just locked. Now how does he get to work? 2 hours every single day. And I want to emphasize that to you because we don't often think about that, but think about your patients, again, children and adults, who are coming to your office. What is the experience like for them coming to your office? We think about, yesterday, right? When the weather, I don't know, maybe in Valhalla it was, a little bit, more. I live in New Jersey, in West Orange, New Jersey. I was in Manhattan yesterday. And, the night before the news spoke about the weather, oh, red alert, snowstorm, it was nothing. It was some rain. It was a little bit of wind. It was really nothing. In a higher elevation, it was something. But, even with that nothing, people think about, getting from one place to the other, that the weather, how it affects maybe icy roads, at night, et cetera, et cetera. Stephen, every single day of his life, had to think about how he was going to get from any place when he left his apartment. And would there be any availability to get wherever he had to go? So again, our patients, if you have a patient who's coming to you who has disabilities that you're aware of, right? If you have a Stephen, seems to me, I would set it up that Stephen, whenever he gets there, I finish whatever patient I'm currently working with, and Stephen comes in immediately, even if there are two patients before him. That's my feeling. Okay, let's move on. Let's talk a little, I skipped one actually, developmental disability, okay? Developmental disability and intellectual disability, which is my next slide, are sometimes often used interchangeably. Typically, a developmental disability is sort of just that. There's a breakdown, let's call it, in development. It can have cognitive pieces to it. It can have physical pieces to it. It can have both. It often has cognitive pieces to it and often significant pieces to it. In point of fact, developmental disability, the term that's usually used within or preferred is intellectual disability, which I'll get to in a minute. But prior to that, for some of you who are a little bit more mature, you might recall the term mental retardation. That was the term that was typically used. It actually is a pretty good representation when you think of the words mental retardation, mental cognitive, if you will, retardation, some stopping, right? And that's really what is often the cognitive piece of developmental disability, is that, or intellectual disability, is that the cognitive development stops at a certain point, whereas for the rest of us, it typically goes much further. Again, intellectual disability, the term that is more commonly used, when a person learns at a slower pace than others, that's a good way to think of it. They could be more mild or severe. Perhaps the best way to think of this is that people with intellectual disabilities typically are concrete thinkers. We use lots of abstract terminology, words to describe things and explain things. That's often where they get lost. If you are concrete, right? If you describe to the patient who is sitting in your chair what you're about to do, in really concrete terms, I'm about to, not your jargon, not my jargon. I'm about to use an instrument. It's a small stick. It's metal or it's plastic. It's got a sharp tip, like a knife. Not too sharp, but a little bit sharp. I need to feel around, to see whatever I need to see if there's some schmutz, some dirt, I'm not thinking of the right dental term, forgive me, but whatever. But again, I hope you hear me describing to Johnny, your patient, as, without the jargon, and explain to him exactly what you want him to do. And if you want him to let you know if it hurts, and I hope you do want him to let you know if it's a little too pointy, or if you're applying a little too much pressure, to introduce that to Johnny. Johnny, listen, raise your left hand. By the way, even that, raise your left hand. I didn't say raise your hand. The Johnnies of the world often might even be confused a little, which hand? You asked me to raise a hand. I don't know. Tell me. We often might say, oh, tell me. What do you mean tell me? You've got something in my mouth. I have no way of telling you. By the way, that's not just for people with intellectual disabilities. You're asking me to tell you? That's one of the, I have to, digress as a patient, right? I often find the dentist will talk to me and ask me questions, right? but I can't, like, right? You got something in my mouth. Really hard to do. Now, I suspect that all you wonderful dentists out there are doing that in part to distract me, not really to ask me a question, but that's the kind of thing that often can be lost on Johnny. So you really want to be clear and concrete. By the way, think of a child. You want to think about it, somebody with intellectual disabilities, and I don't mean this in a demeaning way, but think of most adults with intellectual disabilities remind me cognitively of children roughly 6 to 9 years old. Some more like 6, some more like 9. Almost all of us have children or grandchildren or nephews or nieces. Think that way. And the same way that you would speak to your nephew or niece or child who's 7, respectfully, that's the way you want to explain in that concrete sort of way to somebody with intellectual disability. Now, one of the forms of intellectual disability and developmental disability is Down syndrome. That's a fairly common, well-known, in part because unlike many other developmental disabilities where you don't see any difference, they can be beautiful, handsome. Down syndrome, who are beautiful and handsome their way, but they do have, because of the extra chromosome, their facial features do look a little bit different, particularly their eyes. There are often other health defects that you can't see, particularly heart defects. But here's the really good news. As recently as 20 years ago, 25 years ago, the expectation, the age, the life expectancy for somebody with Down syndrome was about 40. Today, the life expectancy of somebody with Down syndrome is 75. It's changed dramatically, okay? In other words, we know that with an individual with Down syndrome, we can do certain heart procedures, correct the heart defect, and then their life expectancy is really similar to anybody else. Again, I'm going to keep saying this, forgive me, but I want to emphasize to you spectrum. So I can tell you about Karen, who is a middle-aged woman with Down syndrome. Karen reads on a 5th or 6th grade level, reads really pretty well. 5th or 6th grade level, that's the New York Post. That's most people in American society, everybody on this webinar as a dentist, we're in a very small pool of the population. I think it's something like 12% of the United States population have any kind of graduate degree. All right. And we're in an even smaller pool, based on our advanced degree. Okay. Most people read on a 5th or 6th grade level, and Karen did, and read beautifully and understood and everything else. Her math skills, kindergarten level, maybe even less than that. She used to work with me at one point in time in my office, and I would send her down before the age of Keurig, and I would send her down to get, or even when there were Keurigs, I would ask her to get me a cup of coffee. She'd go to the local, coffee shop, and if I didn't have like the exact change, $2, $5, whatever it was, if I gave her a $20 bill, I was going to Atlantic City. I was rolling the dice. If she could come back with the right change, the wrong change, it was completely based on whoever served her and their level of honesty. And if they didn't, they could have said to her, "Oh, it's 20." That would have been it. No mathematical or very limited mathematical ability. Very limited visual spectrum. She had difficulty traveling, right? She could learn a route from her apartment to the office and back and so on, but to get around in general, really difficult. Michael, on the other hand, who worked with her and worked with me in that same office, his reading was only on a 3rd grade level, but his math was on a much higher level. He would never bring back the wrong change. And I could send him any place in New York City, on the subway system, and he could figure out how to get there. But he had intellectual disability. My wife, who is a Ph.D. psychologist, much smarter than I am, she can't, if we go to a hotel, we could be there for a week, can't find our way to the lobby. Michael could find his way anywhere around New York City and the subway system. So I'm giving you these examples, these very real life examples, because we tend to think black and white. He's smart or he's not smart. He's bright or she's not. It's not like that. By the way, for us also, right? We're not all brilliant at everything, and we're all not weak at there's some things we're stronger at, some things we're weaker at. It's more, people with disabilities, again, just like us, but a little bit more intense, more emphasized. So just keep in mind, please, broad spectrum, any two people with the same challenge, same category of disability can look really different. Autism is the disability of the decade, right? For lots of different reasons that we don't need to go into. It's grabbed the attention of society in ways that other disabilities have not, or not to the same degree. Part of that is because of the continuously rising rates of autism, right? Not that long ago, it was 1 in 120 according to the CDC. Then it became 1 in 90. Now we're at the point in the state of New Jersey, I think it's 1 in 35. 1 out of every 35 births are going to be a child with autism. So that's one reason why it's become, we have more and more individuals with autism. By the way, I have to, an editorial note. I mentioned to you earlier, we have, about a decade ago, broadened the definition of autism. And so you're also going to therefore have more people with autism. So there's a lot of reasons why we have more people with autism. One of them certainly is that it is on the rise. Why that is that environmental in nature? Is that due to other reasons? That's a whole talk unto itself. But it is on the rise, but it also, because of the nature of autism, which is fundamentally a social communication disorder. In a word or a sentence, individuals with autism, more than anything else, have difficulty taking another person's perspective. Difficulty understanding, seeing that you and I, who might be in conversation, if I have autism, I have difficulty. I didn't say it's impossible, but I have difficulty seeing that you might have a different perspective. By the way, parenthetically, you might be thinking as I say that, oh, that's my spouse or that's some of my colleagues. But we're talking about as a disorder where there's really significant, some significant degree of taking another person's perspective. Fundamentally, that is what autism is about. It is a huge spectrum disorder at this point in time. And so you have many people with autism who also have intellectual disability, who really have significant intellectual challenges and have the social communication difficulty. And then on the other end of the spectrum, you have people with above average intelligence. You have people serving in the Israeli Defense Forces, in the intelligence division, who have autism. Because ironically, perhaps, or maybe it's not ironic, but some of the challenges that are associated with autism also bring certain benefits. Many individuals with autism have an ability, almost a laser-like focus ability. Isn't that interesting? They can't so easily understand that you have a different perspective, but they can focus in on something like so many of us cannot. They can look at a map that's taken by a jet plane high in the air and look and be able to identify things that their very bright peers without autism have more difficulty identifying. Again, so huge spectrum. If you meet 5 people with autism, you still don't know what autism is. I have met hundreds of individuals with autism, maybe thousands, I'm not exaggerating that. Certainly hundreds, and I have an understanding of autism, but it manifests itself, and it can manifest itself so differently from one person to another. I think the important takeaway is to understand that they have more, what they share in common typically is some difficulty taking another person's perspective. So what's the takeaway for us as people who are working with them? Maybe framing things, asking them questions. Do you understand why I want you to sit in the chair in this sort of way? Or why it's important for me in order to be able to help you, for you to answer these questions that might seem irrelevant to your being in a dentist's office, right? So we want to go into their lives a little bit, if you will, understanding that they have more difficulty with taking that other perspective. Okay, we're going to move on to learning disability. Now, when a person has a learning disability, and there are many, many children and adults who have learning disabilities, their intelligence is typical. Learning disability has nothing per se to do with intelligence. You could be brilliant and have a learning disability, but they have difficulty in one of the processes of learning. It might be in an area such as reading, right? It could be in an auditory processing disorder. That's not hearing. It's different. That's why this is so complex. It could be that they hear fine, but they can't, what they're hearing, they're not able to process in the way that most of the rest of us do in order to understand and do whatever it is that they need to do. Or maybe even they just process more slowly. They may be able to process perfectly as well as you or I, but sometimes, it skips a beat. You know, imagine sometimes you ever watch, you know, on TV, a movie or a show, and somehow the sound is slightly out of sync with the picture, just a little bit. You can catch it. You know, it's out of sync to a degree where you know that it's out of sync, but not so much that you don't see the relationship between what's being said and the visual, if you will. So those are just some examples of learning disabilities. More specifically, let's take one as an example: dyslexia. Dyslexia has come very close to my heart. I mentioned at the top of this webinar that I have a grandson who is 9 years old, Teddy, who has dyslexia. I love Teddy as much as I love all of my grandchildren. We're being recorded, so I probably shouldn't say that. Maybe I love him a little bit more. Because I make it a point to try to spend more time with him. He is very bright. He listens to books on tapes at night for hours sometimes before he goes to sleep. His ability to understand is amazing. And yet, he's in 4th grade this year. Last year, until about February, when he was in 3rd grade, he couldn't read. He could not read. You know, with reading, there's like a code that most kids typically in 1st grade, by 2nd grade, certainly, you know, they break the code and then they just, you know, proceed from there. He hadn't broken the code yet. He was in 3rd grade in a school, a special school for children with dyslexia. He actually has dyslexia and ADHD, which we'll come to in a minute. Attention deficit hyperactivity disorder. So, but the dyslexia, last year, suddenly there was a breakthrough and he broke the code and he began to read. And then just last month, a year later, he really, you know, advanced. And while he's in 4th grade and only reading on a 3rd grade level now, he had advanced significantly. He's beginning to read now. But here's the point I want to make to you more than anything else. Forget the fact that he is bright and personable and kind, an amazing kid, an amazing athlete. Forget all of those things. I once a week I pick him up from school and I do some work with him. I do his homework with him. And part of his homework is to do 20 minutes of reading. I can't tell you how often tears come to my eyes when he is reading, and he's reading. And I am ecstatic that he's reading because I love to read. It's something now that I can begin to really share in common with it. But it is so hard for him to read. Even though he's done it, the energy, the psychological energy, maybe even the physical energy that it takes, it's just hard for him. It's wearying. It's tiring. So I want to now broaden that. That's for a child with dyslexia. So imagine if a child or an adult with dyslexia comes into your office, and as is so often the case in offices, the receptionist gives them a what's it called? Some kind of pad, and some papers, and especially the first time, could you fill these out? So they have dyslexia, but they can read, they can fill it out, but it might be really taxing for them to fill it out, even though they can do it. The energy is just so much greater. And it's something you would never know. Teddy is a beautiful looking, boy, objectively, of course, not because I'm his grandfather, but you would never know. How would you know that he has dyslexia unless you gave him a book? And even at this point, by the way, I'm not even sure then, because he, is really reading. Thank God. Okay. I told you he's got dyslexia, and it's comorbid with ADHD. ADHD is one of those disabilities that is often comorbid with something else, sometimes a learning disability, sometimes other things. Significant number of people have ADHD. Certainly, a minimum of 5% of the population have some form of attention deficit hyperactivity. It's a complex disorder because it's got different pieces to it. The two major pieces are focusing, and I want you to think about this. Attention, focus is really a complex thing. It can really be broken down into so many different pieces. In order for somebody to focus, you first have to grab their attention. Then they have to maintain their attention. Then they have to not be distracted by a noise outside the window or a movement by somebody next to them. And I'm just barely touching the surface on the complex phenomena that is being able to focus. Most of us who are on this webinar probably have no or little difficulty in focusing. That's how, in part, how we've been able to advance, certainly in school. But it can really be difficult for them to focus, and or, the way most people, the association with ADHD is often hyperactivity. Doesn't have to be, but certainly that can be a piece of it. And think of hyperactivity as restlessness. So for children in school who have ADHD and have hyperactivity, school can be purgatory. So imagine a child who goes to school and then comes to your office for dental care after school, and you're asking him to sit and wait in the office and then sit in the chair. So I don't know, who do you take first? Stephen with cerebral palsy, who's it's taken him 2 hours to get out of the house, or 9-year-old Teddy, who's got ADHD, and he really is not so much hyperactive, it's more focusing. But anyways, who's been asked to sit still most of the day, and that's exactly what is so hard for him to do. The other part is impulsive, right? A child with significant ADHD, who's sitting in your chair, that's a child who, if they have significant impulsivity, might not be thinking about it and might grab some of the instruments on that little, table that you've got, next to you. And that could send you all into a tizzy, right? Because it's sharp and they've got to be sterile. And why is he doing that? He's doing that probably because he's impulsive, not because he's a bad kid, not because he's disrespecting you, not because he doesn't understand. But that sharp, that sharp pointy thing is also shiny and it's really pretty cool. And what could I do with that? Could I make something with that? Could I use that with my soldiers to make a fort or to dig a ditch in the backyard and do something really cool with it? Oh, so let me see what that's like, what I could do with it. Without thinking, because they're impulsive, that they're in a dentist's office and maybe the dentist doesn't want you touch that, and in fact needs you not to touch it. So the dentist is working with a child who has ADHD, particularly with hyperactivity, probably wants to try to, keep the instruments a little further away before he's ready to use them, or she's ready to use them. Might also want to explain to Johnny, who has this impulsivity, if you know that, listen, I know that these are, maybe even take the time, a couple of minutes to describe all the different things and let them ask the questions that they have about these things, and to touch in a directed, supervised way these things, because then, right, they've gotten it sort of out, and there's less of a need around those things to be impulsive. I've touched on, 8 to 10 different areas of disability, ones that I think are, again, more common, some that are obvious, some that are not. You don't know that you have a child with ADHD unless you know that you have a child with ADHD, right? The child who comes into your office, you might think they're misbehaving, they're annoying, but it might be that they have ADHD. So I think that, one of the things that you want to do before you do anything else is ask about these things, right? If it's a child, to ask the parent. If it's a child who's old enough, to ask the child, what if you know that they have something, why don't you ask the child, the 9-year-old, my Teddy, if you asked him, he used to be very shy, he's gotten a little bit less shy, but if you ask him, and if you give him choices, like, I heard that you have ADHD, can you tell me, do you feel, when you have, what does that feel like? Or, what should I know? What do you want me to know about you? What do you want me to know about you? What will help you be in the dentist chair and be comfortable in the dentist chair while I clean your teeth or take care of your cavity or whatever it might be? Have a discussion. And even with somebody who is intellectually challenged, again, think a 6 to 9-year-old. You could have a conversation with a 6 to 9-year-old. Again, if they're intellectually challenged, you might need to be more concrete and give them more choices as part of the answers, as opposed to somebody who's got no intellectual challenges, where you can be a little bit more, broad and abstract in terms of asking them to describe what they need, what they want, what questions they have, etc. Okay. I said I was going to stop at certain points, and I haven't kept to my word. But maybe we have a few more slides. Maybe I'm going to continue, and then we'll definitely have time at the end for some questions. So, Chaim Gounod was a psychologist at the early part of the 20th century. And he spent a lot of time in education, working with children and teachers. And this was something he wrote. I've come to a frightening conclusion. I am the decisive element that creates the climate. It is my personal approach that creates the climate. It's my daily mood that makes the weather. As a teacher, I possess tremendous power to make a child's life miserable or joyous. I can be a tool of torture or an instrument of inspiration. I can humiliate or humor, hurt or heal. In all situations, it is my response that decides whether a crisis will be escalated or de-escalated, and a child humanized or dehumanized. These are very strong terms. I want you to know, in my experience of working with children and teachers in schools and out of school, he is right on the money. We can literally humanize or dehumanize. We literally do make children's lives miserable or joyous. The teachers that you went to school with, you remember just a couple of them typically. You remember the teacher who made your life miserable. I remember the first grade teacher who sent me out of the class to the principal's office because I lied that I had done a page in the workbook that I couldn't find in the workbook. And I raised my hand to say I was finished when I hadn't done it. Sent me to the principal. Scarred to this day. Actually, I think in many ways actually also inspired me. And I can think of and you can think of the teachers who have inspired you. I'm thinking right now of a young man who has Tourette syndrome and ADHD and went through school thinking he wasn't smart until 11th grade. In 11th grade, he had a teacher a science teacher, his biology teacher, who said to him, Johnny, you're a smart guy. I don't know if he said those words, but he communicated, I know you are very capable and I'll support you. I'll work with you, but you're going to do a work. You're going to do amazing work. And he did. And then after that, he decided, oh yeah, college, actually honors program for college, actually graduate school. One teacher. You're not teachers necessarily. You're dentists. But I share this slide with you, because it doesn't matter if you're a teacher or not. This is all of our interactions. It happens to be especially true for teachers, but it's true for you as a dentist. It's true for me as a psychologist. You don't think I can make a client's life miserable or joyous? I for sure can. And so can you. No matter what, now I speak as a patient. No matter what, I don't like going to the dentist. I don't have any disabilities. I don't like going to the dentist. So the dentist can make it a more comfortable experience for me or a less comfortable experience for me. They can ask me, how we sit the chair, right? It's funny when I go to the dentist, those neck rolls that you take on airplanes, right? So I bring that to the dentist because I find that when I sit in the dentist chair, when I have that support, it hurts my neck less. Why doesn't every dentist offer that in their offices? Because I think many people, you don't have to have a disability, would be more comfortable with some kind of neck pillow. The point is that we have a huge impact on people through our interactions. You can look at yourself as a dentist, as a technician, as somebody who just cleans and fixes teeth, and that's very important work. But you could do so much more in either direction. You could really, really make it, if not a joyous experience, certainly a less uncomfortable experience. Again, this is from education, but I'm sharing this with you because I want you to understand that before the individual with disability, and this is especially around children, before they come into your office, before the parent who's accompanying a child comes into your office, this is so often, to this day, what parents experience just around school with a child who has any kind of disability enough to be identified. Before the case conference, I looked at my almost 5-year-old son. I saw a golden-haired boy who giggled at his baby sister's attempts to clap her hands, who charmed adults by his spontaneous hugs and hellos, who often became a legend in places visited. Because of his exquisite ability to befriend a few special souls who often wanted to play peace marches. At the age of 4, went to the Detroit Public Library requesting a book on Martin Luther King. After the case conference, I looked at my almost 5-year-old son. He seemed to have lost his golden hair. I saw only words plastered on his face, words that drowned us in fear, words like primary expressive speech and language disorder, trying to say that 5 times quickly, severe visual motor delay, sensory integration dysfunction, fine and gross motor delay, developmental dyspraxia, and Ritalin now. In other words, medicate the child now so he's not acting in any way, shape, or form that might be challenging or uncomfortable. And this parent writes, I want my son back. That's all. I want him back now. Then I'll get on with my life. If you could see the depth of this pain, if you feel the sadness, then you would be moved to return our almost 5-year-old son, who sparkles in sunlight despite his faulty neurons. Please give us back my son untouched and undamaged by your labels, your test results, your descriptions and categories. 1/5 of the population. Now you might think, what does this have to do with me? What are you telling me about education? Because the parent who comes into your office with a child, or the individual, the teenager or the adult, I want you to understand just a bit of what they experience just in school. That's before you get to the playground. That's before you get to the parent who calls another parent about a play date, and the second parent's not interested because your child has some kind of special needs. We don't want to be, contagious maybe. Just in education. So when the parent comes into you and they're wearing their coat or their sweater like armor, where they're almost belligerent for, before it even begins, what are you going to do? How are you going to do? Well, let's take a step back and just try to remember that so often they are assaulted, and I'm using that term consciously, assaulted by the very people who are supposedly there to help them. I have been at hundreds of case conferences and sat with parents. I've been a case as a parent, and you have 5 or more professionals on one side of the table telling you who your child is, not necessarily describing what some of the difficulties are and how we're excited to fix it and what some of the strengths are, but telling you who your child is and the deficits and difficulties they have. That's why I share this with you, because that parent is going to come into your office, or that child is going to come into your office. And by the way, not everybody is like this. Not everybody has experienced this, but I hate to tell you that this is so common an experience that I would be derelict if I didn't share with you that this is so often the experience of parents around their children with special needs, and certainly individuals with special needs themselves. I'm going to go through. Here's a teenager with autism who doesn't speak, but has no intellectual challenges. And by the way, at the, I guess, the slideshow through Touro, I'm happy to make, anybody who wants it, you're welcome to have it afterwards, and you can reference it later. But here's a 16-year-old eloquent teenager who's written to a policeman about what it feels like to have autism. But again, I want to touch on the parents again for a minute. And I think you have to always ask yourself the question, are the concerns of the parents the same concerns as the child? Sometimes they are, and sometimes they're not. So who's the client? Who's the client? Is your client the 7-year-old patient that's brought to your office, or the parent? Right? And there's no black and white answer to that. And it gets even more murky if it's a 16-year-old client. More murky if it's a 39-year-old client with mild intellectual disability. So I just want to make the point to you that the parents are the parents, and it is important, I believe, to validate their feelings. It doesn't mean that you have to affirm their concerns, right? Parents have concerns that sometimes are legitimate, but sometimes are not, because the parent is not the child. But their feelings attached to those concerns are always legitimate, just as our feelings are always legitimate. Just wanted to point that out to you. A couple of points, bottom line, if you will. We always want to make reference to the person, not the disability. So it is, I have a child with dyslexia. I have a grandson with dyslexia. I have a son with Tourette syndrome, not a Tourette's, an autistic, etc. Now, I do want to say that some elements of the autism community, particularly those, who have no intellectual disability, have actually taken to, almost wanting to be referred to as autistic. I think really the takeaway here is a person is not their disability, okay? And then you want to refer to an individual in the way that they want to be referred to, right? The two sub-communities, so to speak, that sometimes almost take pride in their difference are, again, some small subsection of the autism community, and also sometimes people with hearing impairment also, want to be referred to as deaf. Generally speaking, most people don't want to be referred to in those sorts of ways. They want to be referred to as Jeff, who has a disability, whatever that disability might be. They don't want you to be their caretaker. You can offer help, You can ask if they would like any help, if you can help them, but don't offer, don't give them help that they haven't asked for. Really important. And just to emphasize that a little bit more, I want you to think about parents and grandparents who are getting on in age. Many of us have the experience that with our parents or grandparents who are getting on in age, where we might have the instinctive reaction of wanting to do for them. And it comes from a good place. We think that it's hard for them to lift something or do something, and so we want to help them. But there's a difficulty there, and we are unintentionally, I think, being disrespectful. Disrespectful. I don't want to disrespect my parents or grandparents, and neither do you. So I may want to ask my parent or grandparent who's getting on in age, do you need some help with that? Would you like some help with that? And it's that same kind of thing with an individualized disability. Physical disabilities, right? Development we want to speak to that person first, even if they have a caretaker. If they refer us to the caretaker, that's fine. If they say, listen, just ask Donnie or ask Donna, she'll, okay, great. That's because you've asked me to. People, who are mobility impaired and who might be sitting in a wheelchair, you especially don't want to be talking down to them. Can you imagine, what that feels like? You want to bend down to speak to them, or at least sit in a chair and pull up that chair next to them. Another example, right, for somebody who has hearing loss, right? So you want to get their attention by gently touching them on the shoulder or, waving. I think I made the point here is, first and foremost, individuals with disabilities, whether they're children or adults, are human beings with feelings, with likes and dislikes, with personality. Sometimes we confuse personality with the disability. One of the myths that's out there that I've heard my whole career is that people with Down syndrome are stubborn. I have yet to see a study, any kind of empirical research that says that people with Down syndrome are stubborn. But it's out there. And a lot of people who work with people with who have Down syndrome think that people with Down syndrome are stubborn. I don't believe that at all. I think some people with Down syndrome are stubborn. I think Chef Lichtman is stubborn. That's my personality. That's their personality. So let's not confuse personality and the actual disability. And I guess the last thing I want to say to you, and then I'll open it up to questions and comments, is that, I think after a webinar like this, after a series, even if you come to all of these webinars, you're not an expert in disabilities or working with people with disabilities, nor does anybody expect you to be. You know what I will challenge you to be and ask you to be? To be a kind, caring, sensitive human being. I would challenge you to remind yourself that anybody who comes into your office could be your child, your brother or sister, your mother or father or grandmother or grandfather. And the way that you would like them to be treated is exactly the way that you should treat them. And if you do that, right, this is not rocket science. If you treat individuals who have disabilities as not an expert, and don't think because you worked with a couple of people, I just last week I had a kid with ADHD, no issues. No, you don't know anything about this child with ADHD. But you know what you do know? You do know what it feels like to be a parent or a sibling or a child. That you do know. So remember that. Be that. And treat your patients the way that you would want, again, your child, your parent, your brother or sister, yourself to be treated. So thank you for listening. And I'll be happy to take any questions or comments. Again, I will share, the dental school has the this PowerPoint. And so anybody who wants it, to reference any of the readings or anything else, please feel free to request it. I hope I'm not, misspeaking and saying that the dental school will share, but I hope that you are able and will make it available to anybody who wants it. I also have my contact information here. Very simple, jeff.lichtman@touro.edu. So if sometimes somebody has a question or, that they want to take offline, that they don't want to ask, or even, 6 weeks from now or 6 months from now, you have a client who might come into your office and you're a little bit, if you think that I might be able to help shed some light and make it easier and better for you to work with that patient, please, I share this with you and you are welcome to reach out to me. So again, thank you for listening and any questions or comments. And since I'm a little bit technologically challenged, I can't see if there are any.
Thanks, Jeff. I have a quick question, and I know there's one question in the question and answers, but how, many people have emotional difficulty with engaging with individuals who might present, let's say, the spastic CP or the individual who is autistic. They may have emotional difficulty of relating or have fear of relating. How do people get over that?
Okay, that's a great question. And some people might disagree with you with what I'm about to say, but this is my feeling. When I was, I finished college and I went to Israel and I began rabbinical school in Israel for a year. And my wife, who was not yet my wife, and I were going out at that time. And that year, while I was studying rabbinical school, she was working in a clinic, and an all-day clinic for children with autism, with significant autism. I promise you, I am not exaggerating. I visited her 4 or 5 times, over the course of the year. I would go there. Now, let me backtrack. I had plans to finish rabbinical school, go on to graduate school in psychology, and I wanted to work with children in and out of school, and children on both ends of the spectrum that I knew then, kids who were gifted and talented, and kids with, at that point, I only knew about learning disabilities. I really didn't know about much beyond that. Okay, so I go and I visit her. These are kids who were really severely challenged with autism. They would spin objects, they would spin themselves, they would, little verbal communication, etc. And I do not exaggerate when I tell you that I said to her on several occasions, Ellen, how do you work with these children? I don't know how you work with these children. And here's the key point. I promise you, I said, I could never work with these children. And I meant it. That's what I thought. A few years later, after school, after I finished graduate school, I worked in a school, that had children with special needs. And over time, lo and behold, I could work with children who had special needs, including significant physical challenges, including children whose diapers needed to be changed, right? And everything else, because I was open to it. Even though I didn't think I could really, and I promise you, I didn't think I could. But life and I thank God for this, really, that He afforded me the opportunity to have that experience, to come into contact with, and I learned to. So that's a long-winded way of saying I don't believe, you can disagree with me, I don't believe that anybody is incapable of working with other human beings who have whatever significant area of challenge they have. You might think you have that, and you're entitled to that feeling and that belief. But I think it's more about ignorance and a lack of experience. We are fearful of anything that we are not used to. We are uncomfortable by definition. All of us are uncomfortable with anything that is unfamiliar until it becomes familiar. So, slow step, if you're interested, offer yourself, give yourself the ability, the fellowship that Susan mentioned. What a great opportunity to, in a structured sort of way, begin to become, to make that which is unfamiliar familiar. That's my.
Okay. Last question, I guess.
I think an adult who thinks they have dyslexia, how should they go about getting tested and where should they start? Okay, great question. Specifically for this, okay, if you suspect you have dyslexia, then you should go to a psychologist for an evaluation. But, and this is really, really important. By the way, I think this is a good analogy, but Ronnie and Susan, if I'm wrong, stop, cut me off. I think in dentistry, right, you have, general dentists, right, and dentists who do general dentistry, and then you have specialties, right, or, all sorts of, and by the way, in medicine also, you have an internist, and then you have specialization. To get an evaluation to determine dyslexia, you do not want to go to your local neighborhood psychologist. You do not want to do that. And even when you speak to another parent who says, "Oh, I took my son or daughter to the psychologist, they were great." No, in order to get a good, accurate evaluation around dyslexia or anything else like that, any kind of learning issue, you want a psychologist who specializes in evaluations, who does a lot of them. I have read and probably thousands of evaluations. I've done several hundred, but I generally don't do evaluations. That is not my area of expertise. You need to do a lot of it to be good at it. My wife, on the other hand, is a developmental psychologist also, and worked in a school district and primarily did evaluations, is amazing at that. Really, really good. You need the diagnostician, and the person who's a good diagnostician is not necessarily the good person, in terms of now, okay, what do we do with it? I'm really good. You give me an evaluation. You show me the child has dyslexia. I can help the individual, the parent, the teachers, know what to do to help remediate and help support. But I'm not good at doing evaluation. So, long-winded way of saying, find a psychologist who specializes in that. And I'll just add, you can contact me, tell me your geographic area, and I'm happy, to tell you. And I'll just add a PS. The other place that's easy to go, many universities that have doctoral psychology programs, particularly in school psychology, but not limited to that, have clinics where their graduate students do evaluations supervised by experts in evaluation, right? So the evaluation itself will actually be done by a graduate student, okay? But it will be typically well supervised by an excellent diagnostician. That is a way of getting an evaluation for dyslexia or something like that at relatively low cost also. So, which is sometimes, a consideration. So you can go to a university that has those kinds of clinics, or you can contact me and I'll try to help you find what you're looking for.
Okay, I will turn it back to Susan to wrap it up.
Thank you so much, Dr. Lichtman. I'm going to ask you to stop sharing your screen for a moment here, and I'm going to share mine.
Okay, and I think I even did this, right?
You got it. And just to thank everyone for being here tonight, mark your calendars. We do have coming up a little bit of change of pace. We have Gary Sasto, an attorney, and he's going to be talking in May 17th on legal ethical considerations when treating patients with special needs. Be on the lookout as we get closer to that date for our announcements, because Gary has said that he will be willing to take questions before the event. So if you have questions regarding issues of consent, talking about self-determination, capacity, competency, any questions of that nature, he definitely will be taking questions. So we will send you that information as we get closer to the event. And just as a reminder, please return your evaluation forms to Stephen Zelig. He will send those out to you, and you will receive your 1 CE credit upon Stephen receiving that evaluation form. Thank you so very much, everyone. Have a wonderful night.
Thanks.